This article, titled MRI Findings in 6 Dogs with Ependymoma of the Brain and Spinal Cord, delves into the magnetic resonance imaging characteristics of ependymomas in dogs, which are uncommon tumors arising from the ependymal cells lining the brain's ventricles and the spinal cord's central canal. The study is a retrospective, multicenter, secondary analysis of a case series that included 6 dogs with histopathologically confirmed ependymoma, 3 intracranial and 3 spinal cord cases. The primary aim of the research was to provide a detailed description of the MRI findings in a larger population of dogs with this type of tumor, as the existing literature is sparse, with only a few case reports, textbook examples, and brief descriptions within larger case series. The introduction highlights that canine ependymomas are uncommon neoplasms arising from the ciliated epithelial cells lining the ventricular system and the central canal of the spinal cord. Intracranial ependymomas are most often found within or adjacent to the lateral and third ventricles. Previous reports described them as having well-defined margins, low to intermediate signal intensity on T1-weighted images, high signal intensity on T2-weighted images, and variable contrast enhancement. Additionally, they can sometimes present with intralesional cyst-like structures and hemorrhage. The introduction also notes other differential diagnoses for ventricular-associated tumors, such as choroid plexus tumors, ventricular meningiomas, oligodendrogliomas, lymphoma, and neurocytomas. Spinal cord ependymomas are usually located in the thoracic or lumbar spinal cord, causing a focal mass or a fusiform pattern. The MRI signal characteristics of spinal ependymomas are similar to their intracranial counterparts. Differential diagnoses for intramedullary spinal cord lesions include astrocytoma, oligodendroglioma, metastatic neoplasia, lymphoma, histiocytic sarcoma, meningomyelitis, ischemic myelopathy, and contusion. The introduction emphasizes the lack of comprehensive descriptions of MRI findings in canine ependymomas in the existing literature, and justifies the need for this study to provide a more detailed analysis. The study employed a retrospective, multicenter, secondary analysis, case series design. Medical records from multiple veterinary institutions were searched for client-owned dogs with histopathologically confirmed ependymomas of the brain or spinal cord and MRI of the lesion. The inclusion criteria required cases to have at least T1-weighted images before and after gadolinium-based contrast medium administration and T2-weighted images. If other sequences were available, they were also interpreted. When available, histopathologic slides were reviewed by a board-certified pathologist to confirm the diagnosis. Clinical data such as age, sex, breed, weight, clinical signs, neuroanatomical localization, and treatment were extracted from the medical records. The DICOM images were evaluated by 3 board-certified radiologists experienced in brain and spinal cord MRI. The radiologists were aware of the final diagnosis and evaluated the images independently using standardized image analysis forms to record the number, location, signal characteristics, margins, mass effects, and perilesional changes. Spinal cord lesions were further classified based on their relationship to the central canal. After the independent evaluations, discrepancies were discussed, and a consensus rating was established. The results were tabulated to identify consistent findings. Table 1 outlines the image analysis forms used for both intracranial and spinal cord ependymomas. These forms included detailed inquiries on lesion number, location, signal intensity, the presence of cyst-like structures, perilesional edema, contrast enhancement characteristics, the presence of T2-weighted hypointensity, midline shifts, and herniation. For spinal lesions, the forms also requested information on the spinal cord segment involved, the compartment of the lesion, and the lesion's relationship with the central canal. The results section explains the initial search yielded 9 potential cases, but after secondary histopathology review, 3 were excluded, resulting in the final inclusion of 6 dogs in the study. The imaging was performed using different MRI machines with field strengths of 0.22, 1, 1.5 and 3 Tesla. The study included 3 intracranial and 3 spinal cord ependymomas. All intracranial ependymomas were located in the forebrain, exhibited heterogeneous signal intensity in both T1 and T2 weighted images, showed heterogeneous contrast enhancement without peripheral enhancement, and appeared hyperintense compared to normal appearing gray matter on T2 weighted images. All 3 cases also presented with caudal transdentorial herniation. 2 of the 3 cases showed intraventricular location, intralesional cyst-like structures, perilesional edema, isointensity on T1-weighted images, strong contrast enhancement with well-defined margins, poorly circumscribed margins on T2-weighted images, and midline shift away from the lesion. The first case, depicted in Figure 1, was a 5-year-old Rottweiler with a third ventricle lesion that extended into the left diencephalon. The lesion contained intralesional cyst-like structures that were suppressed in T2-weighted fluid-attenuated inversion recovery images. The lesion was isointense on T1-weighted images and hyperintense on T2-weighted images and had heterogeneous signal intensity in both T1 and T2-weighted images. The lesion displayed strong, heterogeneous contrast enhancement without peripheral enhancement. The margins were well defined on both T1-weighted post-contrast and T2-weighted images. T2-weighted images showed hypointensity, and a midline shift to the right without subfalcine herniation was noted. Figure 1 shows a series of MRI images with the lesion in the third ventricle indicated by the asterisk. A white arrowhead denotes intralesional fluid, small white arrows denote perilesional edema, and the small black arrow shows the displaced third ventricle. Figure 1b shows a black arrowhead to point out a small region of intralesional hemorrhage. The susceptibility artifact is attributed to the proximity of the air-filled frontal sinuses. The dog was euthanized the same day as the MRI and a necropsy was performed. The second intracranial ependymoma case, shown in Figure 2, was an 11-year-old German Shepherd dog with an intraaxial lesion of the right telencephalon. This tumor had no ventricular contact and showed intralesional cyst-like structures that were suppressed in T2-weighted fluid-attenuated inversion recovery images. The lesion was hypointense on T1-weighted images and hyperintense on T2-weighted images with perilesional hyperintensity. The signal intensity was heterogeneous in both T1 and T2-weighted images. It demonstrated strong, heterogeneous contrast enhancement without peripheral enhancement. The lesion margins were well defined on post-contrast T1-weighted images but not well defined on T2-weighted images. T2-weighted images were available and negative for hypointensity. The dog showed a midline shift to the left and subfalcine herniation and was treated with hydroxyurea and prednisone before being euthanized 38 days after the MRI. The images in Figure 2a through 2d depict a contrast-enhancing intraaxial mass in the right olfactory region. Figures 2e and 2f show an intralesional cyst-like structure that mostly suppresses on the T2-weighted fluid-attenuated inversion recovery images. The small white arrows in 2b and 2c show the acute angle formed at the pial surface between the mass and the adjacent brain, called the claw sign, which suggests an intraaxial location. The small black arrows in 2e and 2f show the presumed vasogenic edema. The third case of intracranial ependymoma, seen in Figure 3, was a 10-year-old boxer with an intraventricular lesion in the right lateral ventricle and an intraaxial mass in the left occipital lobe. The intraventricular mass was associated with the right telencephalon. There were no intralesional cyst-like structures and the lesion was isointense on T1-weighted images and hyperintense on T2-weighted images without perilesional T2 hyperintensity. The signal intensity was heterogeneous in both T1 and T2-weighted images. The lesion showed mild and heterogeneous contrast enhancement without peripheral enhancement. The margins were variable in post-contrast T1-weighted images and poorly circumscribed in T2-weighted images. There was no midline shift. The dog was euthanized on the same day as the MRI. Figure 3 shows the intraventricular mass in the right lateral ventricle denoted by the asterisks. The mass is silhouetted with the cerebrospinal fluid in 3A and shows mild contrast enhancement in 3C. The non-contrast enhancing intraaxial mass in the left occipital lobe is shown in Figures 3E, 3F, and 3G. The spinal cord ependymoma cases included 3 dogs with intramedullary lesions without any involvement of the intradural-extramedullary or extradural compartments. T2-weighted fluid-attenuated inversion recovery, or T2-weighted images were not available for any of these cases. All spinal cord ependymomas were isointense on T1-weighted images and hyperintense on T2-weighted images compared to normal appearing gray matter, had homogeneous signal intensity on T1-weighted images, perilesional T2 hyperintensity and moderate heterogeneous contrast enhancement without peripheral enhancement. None of the cases had intralesional cyst-like structures. The first spinal cord ependymoma case was a 7-year-old Yorkshire Terrier with an intramedullary lesion in the 3rd through 5th cervical spinal cord segments. The lesion was not centered on the central canal. The signal intensity was homogeneous on T2-weighted images. The margins were well circumscribed on both post-contrast T1-weighted and T2-weighted images. The dog did not have syringohydromyelia and was euthanized the same day as the MRI. Figure 4 shows a contrast-enhancing expansal intramedullary mass extending from the 2nd to 5th cervical vertebrae. The mass is not centered on the central canal. Small black arrows in 4B and 4C point to the thinning of the cortex of the laminae of the 3rd and 4th cervical vertebrae, indicating pressure atrophy secondary to the spinal cord mass. The second spinal cord case was a 1-year-old dachshund with an intramedullary lesion in the 8th thoracic spinal cord segment. The lesion was centered on the central canal. The signal intensity was heterogeneous on T2-weighted images. The lesion margins were well circumscribed on T1-weighted images and not well circumscribed on T2-weighted images. The dog had syringohydromyelia cranial and caudal to the lesion. A biopsy was performed 9 days after the MRI. Figure 5 shows a contrast-enhancing expansal intramedullary mass centered on the central canal. The black arrowheads denote spinal cord T2 hyperintensity cranial and caudal to the mass caused by a combination of syringohydromyelia and spinal cord hyperintensity. The third case was a 3-year-old golden retriever with numerous intramedullary lesions and multifocal meningeal contrast enhancement. The largest intramedullary lesion was in the 11th and 12th thoracic spinal cord segments. This lesion was not centered on the central canal. The signal intensity was heterogeneous on T2-weighted images. The margins were not well circumscribed on either T1-weighted or T2-weighted images. The dog had syringohydromyelia cranial and caudal to the largest lesion and another smaller intramedullary lesion in the 10th thoracic segment. There were also multiple regions of contrast enhancement in the periphery of the spinal cord. A biopsy was performed the day after the MRI. Figure 6 shows the contrast-enhancing intramedullary lesion not centered on the central canal of the spinal cord. The images also showed the multiple subtle regions of contrast enhancement involving the pia mater and white matter, which were thought to represent drop metastases. The discussion section of the article highlights that the MRI features of canine ependymomas overlap with those of other types of neoplasia, emphasizing the diagnostic challenge. Intracranial ependymomas consistently had a forebrain location, heterogeneous signal intensity on T1 and T2-weighted images, heterogeneous contrast enhancement, and high T2 signal intensity compared to normal appearing gray matter. These findings are consistent with previous descriptions of low to intermediate T1-weighted signal intensity, high T2-weighted signal intensity, variable contrast enhancement, and intralesional cyst-like structures and hemorrhage. The margin delineation of the intracranial ependymomas was variable. The authors point out that intracranial ependymomas can mimic choroid plexus tumors, the most common intraventricular neoplasia in dogs. Choroid plexus tumors, however, are more likely to have infratentorial locations and contrast enhancement that is more likely to be homogeneous, with fewer showing signal heterogeneity in T1 and T2-weighted images, or intralesional cyst-like structures. The authors suggest that supratentorial location, signal intensity heterogeneity in both T1 and T2-weighted images, and heterogeneous contrast enhancement can prioritize the diagnosis of ependymoma over choroid plexus tumor. However, given its higher prevalence, choroid plexus tumors should be considered the most likely diagnosis. Other less likely differentials include oligodendroglioma, lymphoma, ventricular meningioma, and intraventricular neurocytoma. The study notes the lack of literature on outcomes in dogs with histopathologically confirmed intraventricular neoplasia, emphasizing that the prognostic implications of each neoplasia are largely unknown. The intraaxial location of the ependymoma in the German Shepherd was an unexpected finding. The authors suggest that the ependymoma may have arisen from the olfactory recess of the lateral ventricle. Ependymomas should be considered a rare cause of canine intraaxial forebrain masses. The presence of both an intraventricular ependymoma and an intraaxial mass in the boxer was also unexpected. The intraaxial mass was most likely a glioma, but could also have been a postictal change or, less likely, multifocal ependymoma. The discussion also compares the study's findings with those of feline ependymomas. In cats, ependymomas have a supratentorial location, T2-weighted hyperintensity, variable contrast enhancement, and intralesional cyst-like structures. Perilesional edema, obstructive hydrocephalus, and caudal transtentorial herniation were common findings in cats. However, in contrast to the canine cases, cats were more likely to have T1-weighted hyperintensity and did not show evidence of drop metastases. The spinal cord ependymomas in this study all presented as contrast-enhancing intramedullary lesions. These findings are similar to previous reports of spinal cord ependymoma, glioma, and myelitis. The study did not identify any specific MRI features of canine spinal cord ependymoma. The CAP sign, often present in human spinal cord ependymomas, was not present in any of these canine cases. This could be due to species-specific differences in spinal cord size, the spatial resolution of MRI, or the small sample size. The lack of T2-weighted images may also have prevented the detection of low signals due to marginal hemorrhagic changes. The authors noted that spinal cord ependymomas can have a variable relationship to the central canal, with only one of the 3 cases in this study being centrally located, whereas in humans most spinal cord ependymomas are centrally located. The authors also mentioned that one of the 3 cases showed vertebral canal enlargement, which could be caused by pressure atrophy associated with the spinal cord ependymoma. The golden retriever with multifocal spinal cord ependymoma likely had drop metastases based on the diffuse leptomeningeal enhancement. The authors note that these plaque-like lesions can easily be overlooked or misinterpreted as evidence of meningomyelitis. The ages of the dogs in this study were similar to those in previous studies. Intracranial cases were 5, 11, and 10 years old, and spinal cord cases were 7, 1, and 3 years old. Most dogs with spinal cord ependymoma have thoracolumbar lesions, which is consistent with the findings in this study. The study has several limitations, including the low number of cases, the lack of specific technical parameters for the MRI studies, and the lack of brain imaging in dogs with spinal cord ependymoma. The study also did not investigate the accuracy or reliability of the findings or factors associated with outcomes. In conclusion, the study notes that the MRI features of canine intracranial and spinal cord ependymomas overlap those of other diseases of the brain and spinal cord. Although intraventricular masses and association with the central canal are common presentations, this study shows that ependymomas can also form intraaxial or intramedullary masses that are not associated with the ventricles or the central canal. The authors suggest that their results can help create prioritized differential diagnosis lists and emphasize that image evaluators should scrutinize images for evidence of drop metastases and that a biopsy is recommended to confirm the diagnosis. The authors contributing to the article are listed in 3 categories. Category 1 includes conception and design, acquisition of data, and analysis and interpretation of data. Category 2 includes drafting and revising the article for intellectual content. Category 3 includes final approval of the completed article. The authors acknowledge Dr. Maria Teresa Mandara for assisting in the transfer of histopathology slides and Dr. Gwendolyn J. Levine for assisting with case identification. The authors declare no conflicts of interest and state that the data used in the study are available upon reasonable request. The Equator Network checklist was not used. The article includes the ORCID identifiers for all the authors and a list of references. The article also includes supporting information in an online section and instructions on how to cite the article. From Vet Neurojar, keep those minds inspired, hearts light, and tails wagging.